So thank you, Professor, for talking to us today. Just a few questions on your presentation. You spoke about suicide and the involvement of antipsychotics in the prevention
antidepressants. Particular.
And the prevention of suicide. Just, a few things on your relation, on your oral presentation.
Antidepressants are made to treat depression, and depression is a major reason for suicides. So one would expect that antidepressants help to prevent suicides. But
is that true?
In Scientology, we have to look and to count if they really do that. And the only way to see that exact is to compare it in a so-called randomized controlled trial against placebo. That means you take a group of depressed patients, half of them gets the antidepressant and the other half gets placebo.
What do you mean
by chance. This is just a pill without anything in it. It just looks like an antidepressant, but it does not work.
Severe patients are using sort of supporting therapy, maybe psychological therapy, just to avoid the use of just placebo.
Now, this is only in studies. You are just doing this in studies. And then you can count how many of these patients are trying to kill themselves under antidepressant or under placebo. And then what you find is in all studies there is absolutely no difference.
There's no difference.
No, antidepressants do not prevent suicide or suicide attempts.
So what do you think? How can you prevent suicide?
Yeah, this is not a question of pills. It's a question of therapeutic relation. It's the therapist and the doctor who needs to get into contact with its patient, talk about them. It's not a condition you treat with drugs primarily.
So it is a question of human relationship with
yes.
the physician?
With the physician and of course with relatives and friends, but within but within a therapeutic surrounding, of course.
You mentioned different causes not leading to suicide. One is depression. What are the other causes? Can we find, for example, a iatrogenic cause in the suicidal patients?
Iatrogenic causes? You mean caused by doctors?
Yeah. So, lack of interest, because you said interest is important, human relationship is important. Carelessness or lack of interest or expertise by physicians. Can all those causes lead to suicide?
Well, they can lead to not preventing suicide. There are three major psychiatric diagnoses connected to suicide. This is depression, this is alcoholism and other dependencies, and this is schizophrenia. These are the three major, and in a way, borderline personality disorder. And of course, treatment that is not done in a professional way can lead to fatal causes, of course. And if you ask to suicides induced by therapy, yes, we have data showing that in very young patients, 25 years or younger, antidepressants, especially from the group called SSRIs, these kind of antidepressants, even can induce suicides and increase the rate of suicides. But this is only true for young patients.
How about the elderly? We know that, there is a high rate of suicide in the elderly.
Absolute right. The highest rate is among the very old, and in men higher than in women. Yeah. And there's no increase due to antidepressants in the elderly, but again, antidepressants do not prevent suicides in the elderly as well.
Okay. Just one question about the elderly. Because we managed to find something in relation of severe depression linked to retirement. Is this something that happens? Is this true? And, depression in the elderly due to retirement, can this, lead to
absolutely
suicide or, due to a major depression?
Yes, absolutely. Major life events such as retirement can induce a depression, and this is a course we see very often, for example, in my hospital. This is not always, of course, connected with suicidality. Depression needs not to go along with suicide ideas, but sometimes it does. And another thing is what we see is that people began to drink alcohol in a dependent way after they retired.
Okay. I think I've got just one other question for you in still being too severe depression. To which organic cause would you compare severe depression? Would you say, it is more like a severe infection, it is more like a severe traumatism, or it is more like, cancer, let's say liver cancer, so something?
Very hard to say. We have several special issues concerning depression. The first is different from most somatic diseases. It starts typically rather early in life, at the age of 30, for example. So this would rather let you think of multiple sclerosis.
Well, what I'm trying to understand is a psychiatrist allowed to say to a severe depressed patient that maybe, is thinking of self-harm or suicide, is any such a psychiatrist allowed to say that his severe depression is like liver cancer?
No, because typically depression is an episodic course of disease. It starts sometime and it will end sometime. We have chronic courses, but these are the exception. The typical course is episodic, and cancer is not episodic. Cancer is a chronic disease.
There are some patients that commit suicide, but after doing this, they kill siblings, people from their family. What's the meaning?
Yeah, this could have different backgrounds. One background can be, as we call it, narcissistic anger. So if you feel to be maltreated in a very extremely way, then it's like being angry and showing the world what they have done to me, to you. Like you see what they call, in schools, these shootings in schools, Amok, we say in German. But other reasons might be depressive delusions. If you lost the contact to reality, for example, mothers after the birth of a child, they can develop very severe post-birth depression, delusional depression, and then sometimes they think they are the most awful mother of the world. They will never be able to care for the child, and it is better for the child to follow them into death with the mother together. So, of course, misunderstanding of reality. Very dangerous.
Which is the most effective psychotherapy method or approach to treat severe depression, and you think it is useful to prevent suicide?
Yeah, I cannot say which is the most effective because there are only few studies comparing different studies. What I can say is cognitive behavioral therapy is the best studied kind of psychotherapy. We know for the best that it does work, but from a practical point of view, probably it does not really, it's not the most important thing what kind of theoretical approach you follow, but what is your relation to your patient? Are you able to get in contact, to understand your patient, and to give him the feeling that there is somebody caring for him? This is probably in a severe depression the most important thing.
Okay. Just another question, the last one, I promise. Where do you think that the mental disease lies? It is more in the brain, it is in the thinking, it is in the unconscious where?
Well,
where do you go and find it? Or where do you think it lays?
Yeah, these are not different, separated categories, because in the end, it must be somewhere in the brain, because our soul is not independent of material. It's somewhere in the brain, but...
It is brain or it is thinking? Because brain is more something of an organic thing.
Yeah, thinking must have an organic basis.
Okay.
Something is, there's some action in the neurons in your brain going on, and so it's very difficult to separate this.
Okay, thank you.
Yeah, well, you're welcome.